Thank you, Dr. Farrell and Dr. Bittner. I have no personal disclosures. This research was funded by Intuitive for data collection purposes. Laparoscopic inguinal hernia repair still lacks widespread adoption despite its introduction in 1992. 2.5 decades later, the penetration is about 25%. There have been two large database studies that have been recently published that have looked at the laparoscopic hernia repair versus the open repair and compared their morbidity. Even though they both conclude that there are no differences in outcome in these large NSQIP database studies, there was a trending towards higher complications in the open group. Although in the second study by Froelich, when this data was propensity matched, there was no difference. And so we did look at what the robotic hernia had to offer in terms of morbidity and outcomes. We first looked at the outcomes of robotic hernia repair in patients with and without obesity, and compared the outcomes of patients with robotic hernia surgery with open hernia surgery with BMIs of over 30. And the second aspect of the study was we also looked at what was the impact of the previous laparoscopic hernia repair among these surgeons and how did it affect the outcomes. The study methods included a multi-center retrospective data collection from 7 different surgeons, and it included the initial experience of all these 7 surgeons and compared with 100 open repairs from each surgeon during the same period from 2006 and 16. And for the patients where we compared the morbidity of robotic hernia repair versus open repair, in the obese category, we also used the propensity match data for the covariates. Out of the 1,244 patients procedures that were collected, 651 patients had robotic-assisted hernias, and 593 had open repairs. This is a subgroup analysis of the 148 patients that had robotic hernia repair with a BMI of greater than 30, and this was compared with the subgroup analysis of 113 patients that had a BMI greater than 30 and had open operations. Out of these 148 patients that had robotic hernia repair, we were able to use 95 patients for covariate matching, and out of the 113 patients in the obese group that had open surgery, 93 patients were matched for propensity scoring. This is a busy slide, but that it shows both the unadjusted and the matched data. This compares the patients who had robotic hernia repair versus the patients who had open hernia repair in obese patients with a BMI of greater than 30. There was no difference in the demographics that is shown here. When we looked at their outcomes and the clinical parameters, the key differences were that patient in the unadjusted group as well as in the adjusted, in the unadjusted group, the patients had significantly more bilateral repairs. In the matched group, you don't see that because bilateral was one of the covariates for matching. Also, patients who had robotic surgery had significantly more concomitant procedures in the unadjusted group. The mean skin-to-skin time was significantly less in the open group, the open hernia group. When we looked at the complications and the 30-day outcomes on patients having robotic hernia repair versus patients who had open hernia repair, the significant difference in both unadjusted as well as in the matched data include the early postoperative complications. There were significantly less early postoperative complications in the robotic group. When we looked at the reoperations related to the index procedures, the index procedure of hernia repair, in the unmatched population, we did see a significance of less reoperations, although that did disappear in the matched study. In the main, out of the 651 patients that had robotic hernia repair, a subgroup analysis of the outcomes of robotic hernia was compared with patients with normal weight and in patients who were obese. And the key demographic differences were in the BMI that was to be expected. There was a significant difference in the BMI between the normal and the obese patient groups. And the comorbidities were also significantly different. As expected, the obese patient had more comorbidities. The operative time was significantly different. There was a 10-minute difference in the robotic hernia repair in the obese. When we looked at the obese and non-obese patients, when we looked at their complications, there were no significant differences in these patients. There were 3 postoperative complications in the non-obese group, but there were no complications in the BMI greater than 30. We also looked at the impact of laparoscopic hernia repair on robotic hernia repair. Out of the first 7 surgeons, 3 surgeons had minimal to low experience with laparoscopic hernia repair, and 4 surgeons had moderate to significant experience with a previous laparoscopic hernia repair. And we compared the outcomes on these patients. The surgeons with low experience contributed 81 patients. The rest were from the more experienced surgeons. When we looked at the complications as it relates to previous experience, we did not find any significant difference in the intraoperative complications or reoperations. And there were no differences as well in the patient demographics. To summarize, robotic hernia repair was associated with lower rate of discharge to 30-day complications in obese patients, both in adjusted as well as unadjusted groups. And the robotic hernia repair was associated with higher rates of bilateral repairs as well as concomitant repairs, but this was not associated with any difference in morbidity. Also, there was no difference in perioperative morbidity between obese patients and non-obese patients in robotic hernia group, and between the surgeons with and without previous laparoscopic hernia repair. Thank you.
If there's no questions from the audience, my one question pertains to hernias, defect size in particular. Would you give us a general take on the types of hernias that this data largely represents?
This was a retrospective study, and we did not have an AHU's classification of the hernias that we could use to compare. So we, this was a shortcoming. The size of the hernias and the defects was not available.
Okay, thank you very much.
Thank you.